Welcome to today's American Association for Respiratory Care's Perspectives podcast. I'm Lisa Weisenberger, AARC Director of Engagement and Media, and today I'm joined by Dr. Lynda Goodfellow, AARC Director of Clinical Practice Guidelines, and Dr. Ben White from the Division of Pediatric Critical Care Medicine at the University of Utah in Salt Lake City. We're here today to talk about AARC's newest CPG on pediatric critical asthma. Lynda, can you start us off with some background information on what this guideline is and how this particular guideline came about?
Well, thank you, Lisa. And yes, I'm happy to talk about this particular CPG. For background information, it all started in December of 2022. I'd received an email from Dr. Samer Abou-Katane, and he approached me about participating together on a CPG and met at Congress that year. And for about an hour, we just kind of bantered back and forth ideas and processes. And next thing we know, we were seeking an agreement between the American Association of Respiratory Care and then PAARC, which is the Pediatric Asthma, acute lung injury and sepsis intervention, PAARC. And from there, January of 2023, we got a team together and we were off and running. And all of this took place throughout 2 years of the CPG development process. It all took place virtually, which is a little different from some of my other teams. So that's a little bit of background how it all got started. But we met about once a month, and then as we got further and further into the evidence, we would break out into small teams and work through the process until we had our evidence, did presentations on the evidence, and then on the grading process, and then we all started writing. And Ben was our first author of all the names on that CPG. And so if you've not seen the paper itself, or it was published the first Monday of May 2025, and it's in Respiratory Care. It is a free article for AARC members, and generally it will be free to everyone soon who are not members as well. So with that, that's a little bit of background about this. And so I wanted to ask our lead author, Dr. Ben White, what is critical asthma in the pediatric population, and how is that defined in the CPG guideline?
Absolutely. And thank you so much, Lisa and Lynda, for having me on today to be able to talk about this work. Like Lynda said, it was a long process, but we did our due diligence and we're very proud of the work we produced. So one of the first tasks that we gave our group was to come up with a definition for pediatric critical asthma. This is a huge and important challenge because for the past 30 plus years, we have not had a universal definition of critical asthma. And that may seem like a small thing, but many members in our group are celebrated academics who have published extensively on pediatric asthma. And if you ask them what a principal challenge has been, it has been that funding agencies and the people that give us the money to do studies, we don't have a definition for this disease that you're talking about. And so how are we supposed to fund you if we can't actually determine what pediatric critical asthma is? So this was a really important task that we set to our group to set the stage for future investigations. When you talk about defining asthma, and especially critical asthma, there's a couple different ways you can approach it. You can talk about this through physiological means. So we know that our pulmonology tools are pretty extensive for diagnosing asthma in the outpatient setting. This includes things like pulmonary function tests, PFTs, checking FEV1s, and ratios. But that's really impractical when you're talking about critical asthma. You can't have an 8-year-old coming into the ED struggling to breathe and saying, okay, we're going to do some PFTs. Our goal has to be to treat first. And that really limits how you can define critical asthma on those physiologic features that we use in the outpatient setting. So then you're left with two other choices. You can choose to define asthma based on the location that the child ends up in the hospital. So do they only visit the ED? Are they admitted to a ward, or are they escalated to an ICU setting? And do you define critical asthma based on that location? That's attractive because of the ease, right? It's not something you have to delineate much more than did they go to the ICU or not to define critical asthma. However, we have widely variable admission criteria across our country and really across the world in who gets into the ICU for asthma. There are some hospitals in our country that will manage continuous albuterol outside the ICU. There are many that do not, and anytime you have continuous albuterol, you have to be in an ICU. And it gets even more complicated outside of our country, where the delivery of healthcare is not always in large academic centers, as it often is for our children here. So as our group talked about this, location-based diagnosis really was not the best solution to defining this. And so then we came to this last choice we have, which is really treatment-based diagnosis. And that's where we've landed. And so if you look at the publication, you can see this in writing and a nice little graph you can share, but I'll just read it out. So we've defined pediatric critical asthma as a severe asthma exacerbation in children that are greater than or equal to age 2 and less than 18 years of age, which requires hospital admission, is refractory to intermittent and inhaled beta agonists and systemic corticosteroids, and necessitates continued management with continuous inhaled short-acting beta agonists or adjunctive asthma therapies. And in the publication, we have a list of those therapies, and we'll talk about many of them during the recording today. But that covers a really large swath of the children that we're going to consider critical asthma in our country. That there may be some outliers in either direction that we can't cover with that definition, but we think as a group that this is probably a good starting place for our field to define this, so we can power additional studies with this definition.
Thank you for that. That's great. You alluded to some of the frontline treatments. So can you tell us a little bit about those frontline treatments that are given in the ED or in the ICU?
Absolutely. And that has rapidly developed over the last couple decades. We have a couple of governing organizations for asthma that have helped with guidelines in the past, and that includes the National Asthma Education and Prevention Program in the United States. Internationally, the Global Initiative for Asthma has been really transformative for global care in asthma, but neither of those organizations nor their guidelines touch significantly on critical asthma. So the treatments typically on the outpatient side are beta agonists and then steroids. And when you get to the ED, there are recommendations for initiating those therapies. But what to do when those are insufficient to control an asthma exacerbation is really where these guidelines that we've developed pick up. And so giving short-acting beta agonists, giving steroids, either oral or IV, are standard therapy for patients that are coming into the ED. And there's been an increasing use of ipratropium as another adjunct medication, as well as magnesium. And there's been a lot of work done in the last decade about early magnesium use in the emergency department and how that can often prevent hospitalization. That is all well-established research that we weren't covering in this guideline, but it leads into the work that we did, because when those things, again, are insufficient, what do you do next?
So tell us a little bit how the guidelines approach the use of mechanical ventilation and non-invasive ventilation, if that's the case as well.
Yeah, that's a great question, Lynda. So mechanical ventilation is the endpoint for the worst critical asthma. And for all critical asthma across the ICUs in the country, that represents only about 5% of those patients. So critical asthma is already a small cohort in the whole asthma cohort. and mechanical ventilation is even a smaller cohort. And so you can imagine that when you're talking about those types of numbers, it's hard to get a great deal of evidence about them. And so we did have that discussion amongst our group as, do we try to answer questions related to invasive mechanical ventilation in this cohort? And there really is not the studies available to do that in the rigorous format in how we approach these guidelines. So mechanical ventilation is something that needs to be studied. It is really important for us to understand the best approaches, but right now there's not good evidence to guide that. That's not the same for non-invasive mechanical ventilation, though. So when we're talking about high-flow nasal cannula, when we're talking about CPAP therapy or bilevel BiPAP therapy, there have been good studies done in the last couple decades, and we do address those in these guidelines. So specifically, you can ask a couple different questions based on the literature that's available. You can ask, is CPAP or BiPAP better than conventional oxygen therapy? You can ask, is high flow better than conventional oxygen therapy? And then you can ask, is BiPAP or CPAP, this non-invasive ventilation, better than high flow nasal cannula? And so we've addressed those three parts in our guidelines. For the first, we found that BiPAP therapy compared to conventional oxygen therapy does have advantages and can lead to some improved outcomes in those patients. And so there was enough evidence there for us to give the recommendation that we suggest the use of bilevel positive airway pressure over conventional oxygen therapy. And that was one of the stronger recommendations that we gave amongst our 11 different recommendations in this guideline. And so it's a pretty commonly used therapy now across the country for critical asthma, and we think that is the right trend. When you look at high flow nasal cannula, it is something that there also has been a lot of data coming out, especially recently. And some of the most important data has come out in the last couple of years that has shown that the use rates of high flow nasal cannula are quite high across the country. And so it's something that has increased over time. As we all know, high flow nasal cannula use rates over the last decade have skyrocketed, and asthma and critical asthma is no different with that. And so we frequently use high flow nasal cannula in critical asthma, both to deliver aerosols, but also as respiratory support in that kind of 1 to 2 milliliters per kilo dose range as well. Despite that, in the studies that have been studied thus far, high flow nasal cannula doesn't quite have the same strength of evidence as non-invasive mechanical ventilation does. And so in our recommendation, we said we could not recommend for or against the use of high flow nasal cannula over conventional oxygen therapy. And that echoes a lot of what we've seen in the bronchiolitis literature as well, where high flow has been introduced. We see maybe a clinical effect, but the overall outcomes of that patient population may not match the clinical effect that we're seeing. And then the last question, right, is comparing those two modalities, the non-invasive mechanical ventilation with CPAP or BiPAP versus high flow nasal cannula. And here again, there just isn't enough evidence out there to tell us which modality is better to use. So in our recommendations, we said we can't recommend for or against either of those in the comparison between the two. And this can be a little bit confusing when we said we recommend the non-invasive ventilation, but we cannot recommend for or against high flow. The head-to-head, you would think, would be the recommendation, well, we recommend BiPAP or CPAP over high flow nasal cannula. But really, again, when we did these guidelines, we tried to do so in a very rigorous fashion. And when answering that specific question, BiPAP or CPAP versus high flow nasal cannula, we looked at only those head-to-head trials. And there really is not enough evidence there to say one is better than the other. So that is a big area of needed research going forward.
Oh, yeah. Thank you for that detail. That's very interesting. So let's get back to some adjunct therapies. And things like you mentioned magnesium sulfate, and then the methylxanthines, also Heliox. So tell us what the guidelines was able to provide in terms of those adjunct therapies.
Yeah, thank you. So there were 4 different adjunct therapies that we evaluated in our guidelines. And so those included magnesium, that included methylxanthines, which really in the current pharmacology is aminophylline. It is the commercially available methylxanthine that's used for critical asthma. IV short-acting beta agonists like terbutaline and salbutamol are also something we evaluated here, and then Heliox. So of those, the 3 pharmacologic interventions, so magnesium, aminophylline, and IV beta agonists, we've actually done a secondary study, which will come out in the future, trying to compare those 3 together. And so that's just a teaser to look out for that study coming forward. But again, in the guidelines, looking at the evidence for each of those, starting with magnesium. Magnesium has been one of the better studied pharmacological interventions, and as I said, has really come into favor in the last decade or 2 in the US for early intervention. And the use in the ICU hasn't been as well detailed or as well studied, but there's enough evidence of improved symptom management and potentially improved outcomes with magnesium that we think that this is something that should be offered to children with critical asthma. And so we suggest in our guidelines the use of magnesium. The question then becomes, how do you give it? And that is something very unknown. There's data out there that suggests we should be looking at ionized magnesium levels when we utilize magnesium infusions for asthma. That evidence is in the very preliminary stages, and it's not something that most ICUs have access to check ionized magnesium levels. So within our guidelines, we weren't able to address that. And really, intermittent or continuous administration of magnesium either have shown to be effective. And there are a variety of dose ranges that people have used for these in the past, and we detail these in the publication. But again, more research is needed to really look at this and find the best dosages that we can use, the best times to use magnesium. But for all of these adjunctive medications, the idea is that we are attacking a different way of dealing with the bronchospasm than just the beta agonism. And so magnesium has some unique pathways that it utilizes to cause bronchorelaxation, and really it's something that has been quite effective in clinical management. So that is something we suggest. For the use of short-acting IV beta agonists, that is something that has less evidence for it. And we suggest the use of an IV SABA infusion as an adjunct therapy. But it's unclear when and how to do this in similar ways as what we talked about with magnesium. And there are different formulations that make this challenging. So in the US, we do not have IV albuterol as a FDA-approved medication. Internationally, in other countries, they have IV salbutamol, which is the same molecule as albuterol, and that is something that they use quite frequently. In the US, we have IV terbutaline. And so terbutaline is similar in that it's a short-acting IV beta agonist, but it has different concentrations than is typically used for IV salbutamol internationally. And so ultimately, you have to use higher rates of that terbutaline, and it can be quite difficult for our pharmacists in the US because they come in small 1 milliliter vials. But here, the evidence still supports the use of IV short-acting beta agonists for patients with critical asthma, improves symptomology, and again, has some trends and improvement towards improving outcomes with that. The best studied pharmacological intervention for critical asthma is methylxanthines. And that is aminophylline. There's a very long history of aminophylline that goes back even before short-acting beta agonists were introduced. And so these have been well known and implemented in critical asthma for many, many decades. And before aminophylline was developed and isolated, then caffeine was often given in acute asthma exacerbations, which is another methylxanthine. But despite the greater presence of studies and evidence around methylxanthines, its use is still controversial, and it's unclear on where on our ladder of treatments it should lie. So methylxanthines and aminophylline specifically have side effects, and aminophylline specifically has a very narrow therapeutic window. Theophylline is the metabolite of aminophylline that you have to measure when you're using aminophylline infusions. And because that therapeutic window is so small, you have to check that level frequently. There's challenges at many institutions in getting theophylline levels back in a timely manner that can limit the use of aminophylline. But all of that is just to give context to the literature, which says because of that narrow therapeutic window, there is a high rate of adverse effects with aminophylline, especially in the older studies where dose ranges may not have been controlled as much. And you can imagine when these side effects include vomiting and nausea, some of the principal ones, that can be really impactful for a child that has respiratory failure. And the risk of aspiration is not zero with that. That said, aminophylline is a very low cost and highly accessible treatment. And so it is used in a variety of environments and used very successfully in those environments. Anecdotally, and in the literature, that there is some evidence to suggest some improvement in clinical outcomes depending on the study you're looking at. But because that evidence is mixed, because the rate of adverse effects is really notable in that aminophylline grouping, for our recommendation, we could not recommend for or against it. This was something that was very hotly contested in our group because there is concern in some people using it because of those adverse effects, and there's concerns from other people that if they don't have access to that in low resource environments, then children may be harmed. And so even though we've had decades and decades of research on aminophylline, we have very few high quality, high volume clinical trials. And it is incumbent upon us as a field, as the pediatric critical care community, to look at this more if we are going to keep using this medication. And then the last one you asked about, Lynda, was Heliox.
Heliox, yeah.
And that has even less evidence, unfortunately. There was enough evidence that we felt strongly about including it in the guidelines because it is a question that people ask, should I be using Heliox? And there's various mechanical limitations to its use depending on your ventilator setup or your non-invasive setup on using Heliox. And really, we isolated 3 studies that were able to comment on this. But the studies were not robust enough to give a strong answer for or against Heliox use. So here we said, again, we cannot recommend for or against the use of Heliox.
Yes, thank you. So the CPG addressed continuous versus intermittent nebulization for short-acting beta agonists. So explain why continuous delivered inhaled SABA may be better than the intermittent option.
Yeah, that's another really great question because there are widely disparate practices when it comes to use of short-acting beta agonists. And especially if you ask our international colleagues on how they use it, the U.S. is maybe a little unique in how frequently we use continuous albuterol. And some of this has to do with staffing. And I think that's going to be the biggest discussion point here, is that in the US, typically asthma treatments are delivered by respiratory therapists, and other countries don't necessarily have that same professional role developed in their ICUs. And oftentimes the same tasks that a respiratory therapist will do in the US are done by a nurse or another allied health professional in other countries. And so what we find in the literature is that there does not seem to be a significant difference between outcomes depending on if you used frequent dosing of short-acting beta agonists or continuous dosing. And the frequent dosing, we're talking about every hour, every 2-hour type dosing. But what is significantly different is the utilization of the staff in that setting. And so when you're asking a respiratory therapist to come to a bedside every half hour, every hour, and deliver another nebulization, that has practical and really consequential effects on your unit. When you have a limited resource like respiratory therapists, if they're in one space, then they're not in another space. And if you ask them to be in this one bedside all the time because they're giving Q1 hour therapies, then they may be able to not as efficiently help in the rest of the unit and take care of other children that really need their expertise. And so here the evidence says pretty convincingly, at least for our group, that there is lower utilization of RT time by using continuous albuterol. And so though the ultimate clinical effect may be similar, and really we need better studies to know this, between intermittent and continuous short-acting beta agonist, the effect on the RT time is significant. And so we recommend here the use of continuous albuterol over intermittent albuterol, largely for that reason, because it frees up a really valuable member of the medical team to take care of patients, including this patient, in different and better ways.
Well, what are some of the biggest challenges you think may be found whenever a unit is trying to implement this CPG?
I think we've probably all heard this at one point in our time in our medical careers, that when new evidence comes into a field, it takes an average of 17 years for that practice change to reach the bedside. And so I think we are still, even though all of our focus on evidence-based medicine the last couple of decades has made great strides, I think we are still struggling to pull recommendations and pull best evidence to the bedside and convince each other that we should follow those guidelines, right? Because even if we have one or two people in a unit that are really passionate about a certain set of guidelines, it can be a lot of work, not only convincing their colleagues, but convincing the other allied health professionals in the unit that this is the right way to do something when they've done it in a certain way for the last 20, 30 years, and things didn't seem so bad. So one of the recommendations I think all of us are most interested in and happy with in this guideline is our recommendation for a dedicated protocol. And so when you talk about taking care of kids with common disease processes, one of the best things we can do in any institution is standardize their care. Because even if we don't have it 100% right on a given protocol, having a starting point and doing things similar between different providers leads to better care. And that's been shown over and over again in the literature. And so if my greatest hope, and I think all of ours who worked on this guideline, is that if people read it, that the biggest takeaway that they can have from it is, what we should have in our unit is we should have a clear protocol for how we manage this, hopefully adherent to the guidelines. And we'll iterate from there. We'll start at the ground level and have a standardized approach and follow the evidence as it develops as we go forward to make that protocol better.
Well, I hope one day we never hear again, well, this is the way we've always done it, because that's the biggest excuse not to do or not to provide evidence-based practice. Well, are there any gaps in the evidence base that the guideline acknowledges, and then what research is still needed?
Yeah, I think one thing readers of our guideline will notice is the low certainty of evidence that we have for our recommendations. And it's something we clearly acknowledge. Like we were just talking about with starting points, this guideline is a starting point, not a finishing point. And we hope from this, it's going to spur experts and new investigators in our field to really dive into the questions that are out there and that we're posing with this guideline. So what we need in critical asthma is a clear ladder of escalation of what should we do next. Because all of our providers who have taken care of critical asthma know the feeling that asthmatics are going to do okay, right? For the most part, it's very, very unusual to have a poor outcome with an asthmatic after they get to the ICU. Most of the poor outcomes happen with children that can't seek care quickly enough. And once we have them in the hospital, they generally do very well. The morbidity and mortality of this population is quite low. That said, I think all of us who've worked in a pediatric ICU would also acknowledge that some of the most stressful patients that you'll ever have is that critical asthma patient at 1 a.m. that just doesn't seem to be getting better. And even though you know that kid's going to do all right, there are kids that require invasive mechanical ventilation. There are kids that require ECMO. And trying to do the right thing for those patients is an incredible cognitive load for practitioners in the ICU. So what I would love for future investigators to really look at is comparative effectiveness of these different adjunctive medications that we're talking about. That's going to be able to create a situation and a foundation where we can create omnibus protocols for critical asthma in the pediatric ICU. If we know what we should do first or what we should do in conjunction, should we be adding aminophylline in at the start? Should we be using magnesium infusions when we reach a certain escalation point in respiratory support? What levels of BiPAP or CPAP or high flow are most advantageous for these patients? And is there a scoring system that helps guide us to do that? These are all really, really important questions. And so as people look at these guidelines, I hope they think, what would the trial look like? And how can I help develop that to really answer this question even better? Because if somebody looks at this guideline and is left wanting for more concrete guidance on what they should do, I hope the next question they ask is, okay, well, how do we get to that answer? And what is the study that needs to be done? And so there's a lot of work to be done, but we're really hoping that these guidelines help catalyze that.
Yes. So last question here. So let's think about the one takeaway that you would want someone listening to this podcast to remember about managing pediatric critical asthma. And that you've mentioned a lot here, but of all the drugs and the modalities, what's one takeaway that you kind of noticed over and over and over?
Yeah, the one takeaway, and as you can imagine, as going through this process, you pay even a little bit more philosophical attention to those patients under your care that have critical asthma when you're developing a guideline about them. The one thing I would want people who are listening to this and reading the guideline to take away is to not take for granted that patient is going to do better, right? Don't go by that bedside and think, well, it's asthma, they're going to be okay, and so we don't need to do anything different. My one hope there is that people talk to each other, look towards their mentors, look towards their colleagues, and have really good discussions about what's going to be the optimal therapy for these patients. Because that matters. Even if that child is going to ultimately recover, if they can get out of the ICU a day sooner, that matters to that family. If they can be prevented from escalating to invasive mechanical ventilation, that matters to that family. And so I think there is a lot of optimization we can do in our field on how we treat these children, how we care for them and their families. And that's what I would hope people look at, is how can I really optimize their care by having good discussions with my colleagues, good attention to the literature that we've raised in this guideline.
That's fantastic what you said and how you said it. So I hope everyone will take heed of your suggestions there. But I want to say this was a very important experience that I went through as part of this guideline. And I could see that just about every question that we asked, there was a need for answers. And we were able to provide some answers, but not many. And the answers that sometimes we did provide were not very robust, and I know maybe not so satisfying as other questions and their answers. But there is a need for us to pay attention, as you mentioned, and take away some of the advice that you gave us here. And so I'll give you the last word, Ben, and then we'll turn it back over to Lisa.
Well, so I just want to give a huge thank you to Dr. Abusatane at IU and Andrew Miller at Duke. They were wonderful colleagues to work with this. But there is the long list of experts that contributed to this, gave their time and energy, and just deserve all the credit in the world for making this happen.
All right.
Thanks, Lynda and Ben, for joining us today for this informative podcast on the newest AARC CPG. You can visit the Respiratory Care Journal website to read the CPG and learn more. And don't forget to keep an eye on your inbox and AARC.org for our next AARC Perspectives podcast. Thanks for joining us today.